Okay, well, thank you, all our speakers, Dr. Saiful, Dr. Terence, Dr. Rafida, for those talks earlier. I mean, I'm really excited to hear about these things. Some are, reinforcing what we already know, but perhaps some are quite new knowledge for us. In the questions earlier, there was one question to Dr. Saiful about. Um, so I think at the moment, perhaps there are not that many patients with Parkinson's that are under palliative care, perhaps even more so in the community. But if we do, every so often come across Parkinson's patients, how could we seek help or advice, even because we don't come across them so often, and perhaps again, medication wise, or just advice that we could get for most of us. I think especially in community hospice where we may not have specialist access as easily as perhaps in the hospital. And then
Yeah.
just you as well, I'll have some of the others, but while we're there was a question about the role of scopolamine patch in siluria for Parkinson's patients, as it can cross blood-brain barrier. It has the benefit of the non-oral route of administration from Felicia Pagawai Pharmacy. And also perhaps just to add to that, adrenaline, because we have used adrenaline drops before for siluria. So I don't know whether that's something you would advise.
Mhm. Okay, so just try to go on very briefly about it. I think as much as we like to say that we would like to have some sort of a seamless care, that kind of journey is still something that we are still working on at the moment. And the thing about Parkinson that makes it a little bit difficult is that the prognostication can be a little bit tricky. It can fall under the three different trajectories that we see in the different diseases and illnesses. At the start, it's sort of the cancer trajectory where they're stable, and then it moves on to the second period, like organ failures, where they have periods of exacerbations. And towards the end, they have that period that is closer to dementia and frailty. And identifying them at different stages is the most important bit, because that tells you where you are in terms of what is most important with the management at that point on. You may need to discuss more with neurology at the earlier bit, and you may need to talk more a little bit with palliative physician at the end bit. But what is more important is integrating all these three different trajectories. And we may need to talk more about having a combined clinic, identifying patients who would need more care. So at the moment, because that hasn't really been developed yet, what we probably need to look at is why is this patient deteriorating? Who's referring to us? Is it a referral that comes from neurology who need help with palliative care kind of medication and services? Or is it coming from palliative care because this patient is a stable neurology patient but has some other complications such as developing cancer or organ failures? And that can tell us where we can point to in terms of direction of care and what can be done for such patient. And just going on about that question about scopolamine patch, we rarely use them in the UK because at the end of the day, if they're deteriorating slowly, we think about non-pharmacological option. Pharmacological option usually leads to more delirium and things like that, although not evidenced to be more in palliative care, Parkinson's disease patient, but patient with dementia and patient who are older age are at more risk anyway. They do use it quite often in US. I think evidence say it is quite safe at lower doses, but my advice would still be in case of slower deterioration to think of non-pharmacological option. But in the end of life setting, then deal with it the way we deal with most of the patients who have problems with secretions anyway.
Thank you, Dr. Saiful, for answering those questions. You do have one more question, but I'll come
Okay.
back to you in a bit. All right, Dr. Terence, uh, just a similar question to you, perhaps. I think in compared Parkinson's, I think you mentioned, Dr. Saiful, that was 40% of Parkinson's patients have dementia. So dementia is a larger prevalence in our community in general. Again, debating that more patients should probably be under palliative, but then also within the perhaps the patients with cancer diagnosis, there are a significant amount of patients with dementia as well. How could we, obtain advice and help if we are struggling or unsure how to manage, or perhaps even, perhaps for some people maybe struggling with diagnosis even, or medications. How can we, ease this perhaps communication and management together with, hospital physicians perhaps?
Gosh, you've thrown me a tricky one there because what you've done is hit the nail on the head with regards to access to specialist care and access to secondary care in the hospital. For instance, memory services that we run in PPUM. I don't admit to having an easy answer for that. Geriatric medicine, psychogeriatrics, which means psychiatrists with an interest in older people conditions, there are not that many of us. To have a consistent national coverage is tricky, but what we are seeing is certainly within geriatric medicine, and so certainly an expansion in terms of training numbers, in terms of specialists. So certainly in due course, we will hopefully be comfortable and confident in saying that there will be, certainly geriatric medicine services consistently across the country. So that's where we're working at. It doesn't help the problem now with regards to, right, if you need help, where do you go to? But I like to think if you look hard enough, there will be a friendly geriatrician, perhaps not around the corner, but certainly a few corners away. We certainly do get referrals. We are approached from colleagues outside the Klang Valley in PPUM, and we are happy to help in any way possible. So I guess reaching out to geriatricians, there is a Malaysian Society of Geriatric Medicine, which would list every practicing geriatrician within the public and the private sector. So access is there. Perhaps it's just finding one of us, linking with one of us. And I've always said that geriatricians in general are more than happy to expand and try and help and support some of these patients, especially outside the four walls of our outpatient clinic, because that's where most of the care happens, not within our clinics or within our hospital setting.
Thank you, Dr. Terence. I mean, I really I agree with that. It's about improving the system and access. And I think because of the perhaps the need for improvement of primary care, which would, in other countries or in the UK would be that middle person between, secondary care and perhaps community palliative care. But
Can I
definitely
just quickly add to, sorry,
yeah.
just remember, I just going to quickly add to that, because one of the things that we are trying to do behind the scenes is come up with a national dementia action plan with key stakeholders from within different the ministry, within different NGOs and so forth. So again, watch this space. The last health administration was certainly very keen on something along these lines, a big national dementia action plan. Hopefully, new administration will carry on some of the work that has already begun. So yeah, exciting times with regards to dementia care.
Well, definitely looking forward to that. So we'll be hearing from you soon. Thank you, Dr. Terence. Okay, Dr. Rafida, we've got a few questions. I had one myself about you mentioned about medication and the fact that furosemide is widely used, but most of our patients are on maximum doses. And I do try to move on to bumetanide or metolazone once we are on the high doses of furosemide, but we don't have them in the community, which was what you said. So I mean, thankfully, hospitals Layang are very helpful in providing us if we need. But do you think there's any possibility that we can have these, I don't know, more accessible to perhaps palliative settings, access to these medications? That's one. Then we have a question for you from Nur Hasima, Dr. Nur Hasima, about EPO in end-stage renal disease with anemia. And another question about how far the nephro team would support end-stage renal failure patients who are managed in intensive care units. When would you institute the idea of palliative care from Dr. Muhammad Fazli? Are you okay with those three questions?
Yeah, absolutely. I think I can answer them. I need 2 days to answer it fully. But basically, access to diuretics. I think most nephrologists would have access to diuretics, so it would be a more of a how do you implement it in the community. So, but quite possibly, if you are attached to a nephrology unit, we can prescribe that quite freely. So, how is that going to be available? Maybe they have to sort of, the medication need to come from our side, into the community. Hopefully, all the patients have access to some nephrologists within that distance. So I hope that's fine. The second one, the question about the EPO. Okay, anemia is something, there's no evidence obviously in palliative care, but again, nothing much evidence that or trial you could do in palliative care population that we know. And I personally give EPO for my non-dialysis therapy, but again, the problem is the budget. again, we're talking about budget, same as the diuretics, the budget and how do we get there. So I think again, the aim is actually, different patients have got different aims. Every treatment should be individualized. So those patients who are on non-dialysis therapy, we probably do not really check the hemoglobin if they're already towards the end of last few weeks of life. But I also will add erythropoietin into the garis panduan that we're doing. So we're going to add long-acting erythropoietin, which is the Misera, or the once in 2 weeks, so that's more is better. But again, the issue is budget. Okay, so but I do give, yes. The last one is actually end-stage kidney disease in ICU. Okay, most of my own patients, they, I do have, I discuss advanced care plans with them, and I can tell you none of them wanted aggressive treatment. So most of them won't land in ICU. That would be the best, right? But if you actually land in ICU, I personally would be very active in discussing with the patients, families. Sorry, can't discuss with patients, obviously. With patient's family, if it's not reversible, I would withdraw. Okay, that's number one. Even AKI with multiple comorbidities, I don't offer dialysis. And of course, not just not offering, we need to address all the total pain components of the patients, of the families at that time. So I personally get very involved very, very early. But of course, that's because of me. I've got special interest in palliative care. I'm actually doing a PhD now as well in palliative care. So I hope to impart that to my colleagues throughout the country. Thank you for the questions.
Thank you so much for that, Dr. Rafida. I mean, just to say that, we do look after a quite significant number of end-stage renal failure. I mean, at Kasi, we definitely do. And it's just marvelous to see the quality of life that they can get without dialysis. Some of them, we have to review quite rarely because they're doing so well. And it just shows that, it's not always about, active treatment, dialysis. They could actually do good quality of life. Obviously, at some point they will deteriorate, but you could argue they maybe even prolong their lifespan to a certain extent. So we do see that in the community. So we really believe in that. I'm very aware that we've reached 1:30. I guess what we could do is there are a few more questions, but if anybody feels like they want to leave because it is actually the lunch break at 1:30 to 2:30, maybe I'll keep, if the speakers are okay to stay, just ask you the next couple of questions, and whoever wants to stay can listen in. Is that okay? Dr. Saiful, what stage? I think you did answer this in your talk, but anyhow, what stage would you suggest for neurologists to refer to palliative care, especially as we know Parkinson's disease progression vary widely from Dr. Norashikin Amran?
Yeah. So the best way to answer that question is look at your patient, talk to your patient. And we also need to ask the question, will we be surprised if this patient, doesn't make it or die in the next 6 months or 1 year? And if the answer is yes, then you need to talk about advanced care planning. You need to talk about goals of care. You need to refer to palliative care if there are any uncontrolled symptoms. And that's really fitting into patients who have Parkinson's disease who are gradually deteriorating. But also another way to look at is because of our growing aging population is that a lot of our patients with Parkinson's disease are also having other diseases diagnosed at any point of their life, and this can be life-threatening, and some of them can be things like cancer, renal failure, and they may not be amenable for disease-modifying treatment because the Parkinson itself is limiting their quality of life. And if such complication arises, then we need to talk about it even earlier, even at the point when the Parkinson's is well controlled with medication, because there will be some of the diseases that will be life-limiting for them. And I'll probably just go on with the other question about when do we talk about stopping the anti-Parkinsonism medication. It varies with different patients. If it's a slow deterioration, then you may need to look at what point is there more complication with continuing this medication. And you may be causing more neuropsychiatric symptoms. And if that is the case, you may need to gradually reduce. Or if the prognosis is made much shorter by an acute complication or a different problem. And if that is the case and we may need to discontinue the medication, then we may need to talk about stopping it and starting them on some other medication to control the symptom that may be made worsen by stopping the anti-Parkinsonism medication. Of course, if sedation is an issue and patients want to be at home, and also budgeting is not an issue, and we can talk about rotigotine patch because it is quite expensive, then we can discuss about that if that is the goal of care at that point of time. But the point of the matter is to really look at your patient as a whole, really need to look at what is happening, what their goals are. That is the biggest topic that needs to be addressed.
Thank you, Dr. Saiful, for that. So one last question for Dr. Terence from Dr. Xiao Yan Ching. Would you comment the differences of mild cognitive impairment versus mild dementia, as there are concerns about the labeling of the diagnosis of dementia, even if it is mild?
Yeah, I think that's a really excellent question and one that I did not touch on. So mild cognitive impairment is still very much a clinical diagnosis. Many sort of consider it like a pre-dementia type stage. But what is important to stress is not all mild cognitive impairment becomes dementia. So how do you separate the two? In one of my slides, we talked about different cognitive domains, but one of the hallmarks of dementia is that it has the ability to affect our activities of daily living. Whereas with mild cognitive impairment, there may be memory lapses, there may be occurrences of unable to recall somebody's name or find the right words, but in terms of how it affects daily living, it doesn't take place. And that's what we would normally label as mild cognitive impairment. Many of our MCI patients are pretty stable for long periods of time, and not all do eventually become dementia. Now, mild dementia, separate, like I said, from MCI. And the reason why terminology and getting the term correct is dementia allows us to then think of perhaps pharmacology, disease targeted treatment, such as cholinesterase inhibitors, which would hopefully help in terms of delay or stabilize progression of disease. So MCI, different, mild dementia, different, importance to get it right. And again, this is perhaps where specialist memory services can step in to try and help disentangle whether it's MCI, whether it's mild dementia, and whether, if it is mild dementia, access to therapeutics is required.
Thank you so much. I mean, that's new to me as well. So, really enlightening. Thank you so much. So, all our speakers, I think, one big. There are many points that we can take back today, but I think if, in terms of moving forward, while we are waiting for our system to improve and all of us doing our part in the system to integrate and fill in those gaps, perhaps allowing that communication, empowering. I mean, I'm talking from a community hospice point of view, but for us to be able to access specialist advice, really appreciate it, because every so often we come across situations where we're not so familiar, but at the end of the day, we are the ones on the ground seeing these patients weekly or several times a week, even if they're in a lot, having a lot of symptoms. So we really appreciate specialists like yourself who can advise us in the community. Thank you so much for that excellent session, and thank you everyone for listening in. We are now going to be on lunch break until 2:30 p.m. and we will see you then. Have a good lunch.